Our next speaker is Randy Howard, who comes to us from the Hendersonville Medical Center in Tennessee. And he will be speaking to us today on changes in the number of US patients with newly identified cancer before and during COVID-19. Randy? Randy, I think you've gone.
Good morning. Hopefully you can hear me. I am a gastroenterologist from Nashville, Tennessee, and I just want to give a little background on COVID in Nashville. And then I'm going to go through 3 cases in which we believe the delay in diagnosis probably led to advanced stage disease. So we in Nashville, everything got shut down in March. We were seeing patients and doing endoscopy without much problem until probably mid-March. And then after March to probably May, we were only doing emergent cases. And so we saw patients in February, a lot of which were symptomatic patients. Some were screeners, but a lot of symptomatic patients. My practice, we do about 6,000 endoscopies a year. And a lot of it is symptomatic patients. So from March to April, we did essentially only emergent cases. And I just want to go through a delay in 3 cases, which I believe led to advanced disease. We saw one patient, a young man in February, and had planned to do a colonoscopy on him for changing bowel habits in March. And things were shut down. We only doing emergent cases. So we saw him back in June. On his colonoscopy, he was only 40 years old, no family history. We found a large fungating mass in his sigmoid colon. On staging, he had liver lesions, of which on biopsy turned out to be adenocarcinoma. And the questions always for this young gentleman was whether or not, if we had not delayed his procedure because of COVID, maybe he would not have advanced disease or nodal disease. It's hard to know, especially with colon cancer. It may have been there in February, but it strongly going to impact his long-term survival. The other case is a elderly young lady that we saw in January who presented to us with epigastric abdominal pain, weight loss. Imaging showed what would appear to be a small pancreatic lesion, which we thought probably was a IPMNN, and was scheduled for endoscopic ultrasound again in March. Things got shut down. We revisited the patient in May, but they were apprehensive about coming to the hospital because of COVID. So the patient delayed the follow-up until last month. And on endoscopic ultrasound, the worst case scenario was the patient had an adenocarcinoma with nodal disease and was deemed surgically non-resectable. And in this case, though, I'm very concerned that the delay probably led to the nodal disease, especially in light of how aggressive pancreatic CA is. And the third case is a little bit different. You know, as gastroenterologists, we see patients along the spectrum, whether it's pancreatic, colon, or gastric, but is a patient, a longstanding patient of mine who I had not seen in a while, who presented in January with epigastric abdominal pain and weight loss. And part of the workup, we actually did a CT scan, which was concerning for a gastric mass. But because of COVID, she was reluctant to return to see us. And the worst case scenario was when she came to see us, she actually had a gastric CA, of which she's undergoing workup now. But I am concerned that she will have nodal disease, which will probably preclude her from a gastric section. So all those patients, I feel, have been impacted by COVID and the fact that we were unable to proceed with the workup, which probably led to advanced disease. And of note, we probably only about 50% of the patients that we delayed have decided to return for their follow-up cases. So I'm afraid that we're going to see more advanced disease because patients are afraid to come back to the hospital because of COVID. And I just want to give those examples of patients that we believe will be impacted long term and probably shorten their survival because of COVID and their fear of returning back to the hospital setting. And that's what I have.